thank you. I want to tell you, first of all, I'm very pleased and honored to be here. My father was a Rotarian, retired dentist, down the Washington, D.C. area where I grew up, and went to Rotary meetings, luncheons on occasion with him when I was growing up, and enjoyed those. And the polio, even decades before I went into medicine, recognized what Rotary was doing for polio. And the fact that Rotary has stayed with it until it's essentially cured is one of the great public health stories, I think, of the last 100 years. And Rotary will always be known for that, so thank you. Went to medical school at George Washington University in Washington, D.C., and did my residency there in internal medicine. Graduated from medical school. It'll be 25 years next spring. So I've seen a lot of changes in medicine. I started in primary care right out of residency in 1996. Joined a small family practice group in Alexandria, Virginia, just outside Washington. Spent the first 2 years there, and then when that practice was purchased by a hospital system, I decided to strike out on my own and start my own practice in the area, and I did, and I had that for about 14 or 15 years, and absolutely loved having my own practice in the community. My wife is a native Vermonter and really wanted at that point to think about coming home, so I felt it was a good time for many reasons, and so we came back to Vermont. I came back in 2012, and I worked as a hospitalist then. We'll talk a little bit about that. I'm sure many of you know that's a physician that works only in the hospital as opposed to the outpatient. I did 6 months at Central Vermont and the last almost 4.5 years now at Rutland Regional. So I wanted to talk to you just for a few minutes. I know we just have a few minutes. I'd really like to hear your comments and thoughts. By the way, I think I asked earlier, but is there anyone directly or indirectly involved in the healthcare profession here? And you're with the nursing facility, right, which is an integral part. What I thought might be helpful to do is, and people can debate this, but just to sketch a picture of what medicine was like in general a generation ago, say 30 years ago, and what it's like now, just in a very broad canvas. So I finished in 1993, started medical school in 89, but even a few years before that, in let's say 1985, if you went to your physician, if you were sick or wanted an annual checkup and you went to the doctor's office in 1985, first of all, you would probably actually be seeing a physician. The physician assistant and the nurse practitioner professions were pretty much still in their infancy. They've developed quite a bit, as you know, since then. If you went to see your doctor, you would probably be going to an independent physician, independent practice. Over 70% of physicians, internal medicine and family practice doctors at that time were independent, which means that they were in a practice which they owned or was owned by the practice itself. The practice itself made the decisions for that practice in terms of how they were going to treat their patients and patient load and patient mix, etc. When you went in, you would probably know most of the staff in the office. Turnover was generally low, and you would probably see your own physician. You might occasionally, if that physician was on vacation, you might see their partner, but generally you would see the same person. When your physician came in, they would probably be holding a paper chart, which they might have a computer system in 1985, but it would not have supplanted paper charts at that point. They might have picked up your chart before they came in the office, glanced at it briefly, although because they had seen you each of your visits, they kind of knew what was going on, that had gone on with you in the leading up to that point. When they came in, they might actually look at you and examine you. They might glance at the chart and write something fairly unintelligible in it, but most of the time they would be looking and talking with you. They probably would know your family. They may have treated your parents. They may have be treating your children if they're family practice. And so there's history there. When you left, you would have very little in 1985 in the way of copay or deductible. If you had to go to the hospital, if you were sick enough to go to the hospital, you would probably go to a community hospital. Unless you were in a large urban center or were part of the VA, large urban centers having most of the medical schools and tertiary hospitals, but if you were in a place like St. Albans, Rutland, or even parts of Burlington, you would probably go to a community hospital, which was owned by the community essentially, had its own board, where your outpatient physician would actually come see you in the hospital, and would also be involved with the managing and the running of the hospital. Outpatient physicians then used to fill the boards of the hospital, the executive plan and the planning boards. So they were very concerned with how well the hospital was keeping up its treatment plans. Flash forward. And I should say, in 1985, healthcare as a whole took up about 7% of our GDP as a nation, gross domestic product. Flash forward to 2017. If you go to your doctor's office, odds are you will see possibly see a doctor, but very possibly see a nurse practitioner or physician assistant who are very capable. Whether or not the 2 years of training, the official training that they get, is equal to the 7 years or more of physician training, I'll leave that to another forum. But you would see one of either physician assistant, nurse practitioner, or physician. Odds are you might not see the same provider, and I'm going to call them providers from now on because that's what we call them in 2017. You would not see the same provider on your next visit because it's a large facility and people are constantly shifting around. So you might see someone you hadn't met before or hadn't seen in quite some time. You would be going to, instead of a privately owned physician office, it'll probably be owned by the hospital, as most practices are, certainly in Chittenden County and increasingly throughout the state, probably owned by the University of Vermont from the north or Dartmouth coming up from the south. It also may now be what's called a medical home, which is a construct which is promoted by the federal government, where any number of services are provided within the actual physician's office. That can include social work, podiatry, nutrition, psychological counseling, sometimes dentistry. You may not need any of those services, but they're all going to be available. Something akin to if you go into an emergency room in the middle of the night and only 3 people in the ER, but they've got this huge staff waiting because they have to be ready, fully staffed for anything. So medical home is the new construct. When your provider comes in, they will be wheeling probably a little portable computer. Studies have shown that they will look at that computer for over 50% of the visit. It's not necessarily because they're in love with their computer, although a few are. It's because the government now requires, in order for them to get paid for that visit, for them to go through a checklist of questions to be asked and subjects to be covered in every single visit. So don't be startled if you go in with a sprained ankle and they ask you if you're depressed, if you're feeling depressed. It may have absolutely nothing to do with that visit, but they have to cover that on a routine basis as a screening tool. If you have hypertension or diabetes, they will be almost certainly following now an algorithm of treatment. They need a certain percentage of their patients to meet certain metric guidelines because the new buzzword in healthcare is now population health. It's not necessarily individual health. So physicians are essentially supposed to be treating populations and not necessarily the individual in front of them. If you have to go to the hospital, you will see a hospitalist, almost certainly now. Very, very few outpatient physicians anymore go to see their patients in the hospital unless it's a social visit. And I am a hospitalist. I have great colleagues. We're paid well to do what we do, and I think we do it well. Whether we do it any better than what I used to do, because I used to see my own patients in the hospital when I had my practice. I used to see them in the nursing home. Occasionally even did home visits. Whether we're doing that better or not as pure hospitalists is debatable. The studies are still up in the air. By the way, whether or not the medical home is doing any better is also debatable. A recent New England Journal article from about 6 weeks ago looked at a number of medical indices and found that medical homes actually did not perform any better than practices that had not adopted the medical home. But you will see a hospitalist. You may not even see the same hospitalist each time, and you probably will not have a relationship with that hospitalist. Hopefully you won't. If you form a relationship with your hospitalist, it means that you're in the hospital an awful lot, and that's not a good thing. But that's who you'll see in the hospital. They will send a discharge summary to your physician. Almost certainly they won't be calling them, but your physician will get a printed discharge summary, and hopefully your outpatient provider will have a chance to look at that and get some idea of what went on in the hospital with you. I should say now, 30 years later, healthcare now accounts for over 20% of our GDP, so it's more than tripled, and projections are within the next 5 years it may be as high as 25%, so almost moving toward 400% increase. So that's kind of where we are, and if, it may be a hopeful, some people would say it's a hopeful picture, others would say it's a bleak picture. I should also add, the new construct that's been proposed in Vermont is, and I'm sure you may have heard of it, we were just talking about the Accountable Care Organization, or ACO. This would be formed under something called the All-Payer Plan. When Governor Shumlin was governor, he pushed hard for this and got a waiver from the federal government, as did in several other states, a Medicare waiver, so that Medicare, Medicaid, and private insurances will all pool their money, which before they were not allowed to do. And they will form all of the providers in the state, essentially, the community health centers, the hospitals, and most of the physicians in the state would come under this big, huge organization called an Accountable Care Organization, where they will be paid lump sum. The Accountable Care Organization will be paid lump sum if they can take care of patients, especially meet these metrics within a monetary value. They will, if they go below that value, they'll make money. They'll get bonuses. If they spend more than that, they will actually see a cut in their pay. I will tell you, the ACO, just like the medical home, has gigantic administrative costs. Gigantic. It's tremendously expensive. And the most recent, Massachusetts has the most experience in the country with ACOs, about 8 years now. They have found, it has been found that they actually are not saving money. One can argue that they've been able to provide services such as some outpatient home visits and other things that might not have been affordable or available through regular offices, but in terms of the money saving, because of all the extra services and the administrative costs associated with it, it's as or more expensive. Whether or not your physician will be able to continue to practice outside of this ACO, Governor Shumlin said, if your physician wants to stay independent, they can stay independent. I've often said that sounds to me a lot like President Obama's statement, if you like your physician, you can keep them under the Affordable Health Care Act. Almost certainly physicians will not be able to practice unless they practice under the concierge model. I don't know if any of you have heard that. We only have a few physicians in Vermont that have adopted the concierge model, quite a few in Northern Virginia before I left. That is a model where physicians limit the size of their panel. If they've had 2,000 or 3,000 patients before, now they limit their panel, say, to 400 patients. They charge the patients anywhere from $1,000 to $1,500 a year up front, so that they have the money up front to run their practices. And then the physicians, the patients themselves will send their bills to Medicare, but the physician does not bill Medicare, because that would be against the law. But they have they can practice outside the rather increasingly rigid protocols that Medicare is insisting, and they don't have to feel as rushed as other practices. So I suspect, if we go the ACO route, we're going to see more physicians stepping out to go the concierge model, and that has its pluses and minuses. The minus is it takes more physicians. You have fewer and fewer physicians taking care of fewer patients, so that the rest of the people who can't afford the $1,500 a year up front are going to be in more of a bind finding providers. Anyway, I will stop there. I would like to hear comments, questions, your experiences. Yes?
We're told that we're the industrial nation with the highest healthcare costs, and this is Bernie Sanders' argument to change our system. Is it true that European countries spend less?
They do spend less. There's no question about that.
And get better health care?
Well, yeah, on some of the indices they do. And there's no question about that. Now, it's a different system. And you'd have to talk to physicians and patients who've been in those communities. There's always a give and take. As you know, certain things that we consider fairly urgent are not necessarily considered urgent in many of those countries, unless you have some additional private insurance. And a number of those countries, Germany and Switzerland in particular, have a base, which is a sort of a national health insurance, but then people have add-on insurance. And I suspect ultimately in the United States that's what would happen. I don't know that we're ever going to have everybody having exactly the same insurance. But things like hip replacements, here you can probably get a hip replacement if you're in general good health in about 3 or 4 months or less. There it might be 2 years. You might be hobbling for 2 or 3 years. Even things like coronary artery bypass graft surgery, you can wait 6 months to a year and be treated medically in the hopes that, because there's sort of a waiting list. So there's a give and take. They do put more emphasis on primary care, but they also control, again, what primary care can do. There's rather rigid formularies there in terms of the medications people can prescribe and treatments they can use. So the answer is yes, but it would be a big change from our system. Medications are also, the cost of medications is less, and as you know, Senator Sanders is pushing hard for to be able to import medications, which we already do from certain countries, but he wants to focus particularly on Canada. We'll see what happens with that. One of the issues is whether or not Canada, first of all, can ramp up their production. If all of a sudden millions more Americans are getting their medications from Canada, I wonder how they're going to ramp up their production and how it's going to be paid for. Because remember, Canada basically subsidizes their medications through their taxes, which are far higher than ours, and European taxes are even higher than that. So, how it's not really understandable that they would simply give the Americans the medications the same price Canadians are already paying for with taxes. But you're right, to answer your question long-windedly. Yes?
Doctor, I heard recently that the life expectancy rate for Americans recently has taken a bit of a dip. And I wonder if you know of if there's any particular cause for that. It seems like as medical procedures are constantly improving, right, medical knowledge we would assume is improving. Why something like that would happen?
Well, the demographics are clear. It's dipping in white middle-aged folks, and particularly white middle-aged males. And I think the thinking is they have been, particularly in the Midwestern countries and the Midwestern states and the Rust Belts, they have been hit hard economically, and when you hit hard economic times, it affects people's health care, either access to health care and or just the way they're taking care of themselves. Actually, Hispanic and blacks, people's longevity is increasing, interestingly. So it is in one particular sector that's dragging down the numbers right now. Yes?
I follow the CDC website and organization about the concern about childhood obesity and the dramatic increase in obesity trends in the United States and really internationally.
Yep.
I'm pleased that Northwest Medical Center has really taken hold of that. There's a body mass index process going on this fall for 2,000 students in Franklin and Grand Isle.
That's terrific.
It will be the baseline for beginning to bend the curve like France, Belgium, and Netherlands did, starting in '92. And that process through Rise Vermont is percolating throughout the state and likely will be statewide in the next few years. So
they check BMI, and then is there an intervention associated with that?
Yes, and that's through Rise Vermont.
Okay.
Through a community health initiative.
That's terrific.
That will also partially focus on children.
Yeah, that's true. Well, nationally, the studies I've searched, the curve is, if not bending, it's flattening a little bit. We're making some progress nationally on it in the last several years on obesity, but programs like that are going to be huge because particularly childhood diabetes and heart disease can start early. And seeing a lot more childhood diabetes, type 2 diabetes, which is really more weight-related than anything else. Yes?
I heard you reminisce about the way it used to be. My grandfather was a surgeon at St. Luke's, and my mother worked in hospitals and for private physicians her whole life. And I just remembered that the main hospital in our community was nonprofit, and that's the way they used to be.
Yeah.
Can you describe, because I know you were in the industry around that time, what happened?
Not in your grandfather's time, but
No. He was old. He was a physician.
check my horse and buggy.
No, I'm talking about back in the late 70s. Probably.
Yeah, I hadn't started medical school yet, but
Oh, okay.
you know, a lot of hospitals are still nonprofit. You have to, nonprofit is, as you know, if you're in business, is, you know, simply based on their overall numbers at the end of the year. It doesn't mean that people aren't making a lot of money.
Right.
And the hospital system that, well, look, University of Vermont is nonprofit, and they're making a tremendous amount of money. Now, they're supposed to be spending some of that money, putting that money back in the community, which they are. Green Mountain Care Board has recently, as you know, spanked them a little bit for increased revenue and not putting enough back. But that happens across the country. Nonprofit can include a wide range of facilities. One of the things, too, one of the things that has happened, which is the greatest concern to me, is that with the majority of physicians now employed by hospital systems, and partially I blame my own profession to some extent. The newer generation of doctors wanted to have a different quality of life than their fathers, if their fathers or grandfathers practiced medicine. Whereas I practiced medicine, I had my beeper on 24/7. They don't want that anymore. They want to work shifts, whether it's in the hospital or even in the office. And that was the appeal. They want a sort of steady paycheck. That was the appeal of signing on to a practice that was hospital-owned or having the practice get bought by a hospital. The problem is when physicians give up their autonomy, certain conflicts can arise. The hospital may have, I talked about algorithms, but basically the hospital may have one approach they want everyone to practice, which will be supposedly effective medicine, but also cost-effective medicine, that they're looking at their bottom line. That may not necessarily be best for your patient or your cohort of patients. And the problem is when you're employed, and particularly as, let's say, University of Vermont, let's say you're a physician in Chittenden County, internal medicine physician, all but I think 2 or 3, I think there are 2 small practices that are independent now in Chittenden County. The rest are entirely owned by University of Vermont. If you disagree with the policy at University of Vermont, you can raise your hand, and I'm sure they have avenues where you can make your voice heard. If you do it enough or forcefully enough, or often enough, you're likely to get fired. And if you get fired from the University of Vermont, the question is, where are you going to go? It's prohibitively expensive to start your own practice now, as I did then. If you have children in school in Chittenden County, or if you have a home with a mortgage, you don't necessarily want to move from Chittenden County. In fact, you might have to leave Vermont entirely soon, because they have restrictive covenants, and you know, there's no other practices to go to outside of the University of Vermont. They're going to shut you out. So you know, patients need to think about this as well. You know, at the end of the day, is your physician going to be in some conflict about what's best for the patient versus what's best for the system? Certainly under the ACO all-payer plan, I think that will be a big factor. They're going to have to be thinking about the bottom line, because if they go over budget, they're going to be see their own salaries reduced. And the final thing I want to add is basically, overall thing, I guess the theme is that when the government, whether it's federal or state government, they do a lot of things well. All right, look, when I get on an airplane, I'm glad the federal government and FAA mandate certain checklists to check that airplane, and other such things. But people are a lot more complex and a lot more individualistic than airplane bolts and airplane fuselages. And when the government tries to essentially micromanage what happens within that individual healthcare setting between doctor and patient or between provider and patient, it can really be disastrous. And the example that I usually use is the example of No Child Left Behind in the field of education, which, are you in education? Mm-hmm. Yeah. Somewhat controversial, but started in the year 2000, which was a bipartisan measure to try and lift some of the poor-performing schools, or at least identify the poor-performing schools and then help lift their standards. But the way they did it was they created certain metrics to define what was a poor performing school or poor performing teacher, and these metrics had all to do with standardized test scores. So the teachers ended up having to teach to those tests. And I knew quite a few younger and older, creative, great teachers who left the field or went into administration because they just simply didn't want to simply spend all their time teaching these tests. It really began to change the way teaching was as a profession. We've stepped back from that. I don't know if the new plan, which gives more power to the states, will be any better. But I think at least people recognize that having the government micromanage what is essentially very complex individual interactions is very difficult. And I'm concerned that we're going the same way for medicine, with physicians spending 3 or 4 hours after their doors close in the evening, sitting on computers doing clerical work, as teachers used to do, entering all this input data that someone with a high school education could do, and just getting totally burned out and beginning to leave the field, or certainly not working full-time anymore. So I think it's something we have to think about, don't break something that wasn't broken. So I'll stop there, and I thank you for your time, and I'm certainly here for a while longer if anyone has any questions. Thank you.